folks, thanks everyone for joining. This is chapter 21 of our Critical Care Bouncebacks book. And thank you so much for taking the time this evening out of your day. Hopefully we will be true to the hour that you have given us. And we have a really, really nice panel here for us today. And I'm going to introduce folks in just half a second. I wanted to just start by sharing the screen. And in the end, what we're going to find here is that this case is very important to me because it's the chapter that I actually was the primary author of and the book out of the 30 chapters we have. Just up front, there are no financial disclosures from anybody. Here is the code to claim CME credit. So please scan that in. One important announcement is that we have one more of these book clubs during this sort of calendar year, which will be next month on May 7th. And you can always sign up. Either we'll give you a link here or by going to embouncebacks.com, like emergency medicine bouncebacks.com, and there'll be a link to sign up there. And then we'll take our summer break and resume in October. And that's because the first Monday in September is Labor Day. So here is our panel. We have Whitney Johnson, who I had the absolute pleasure of spending time with just last month. Had some great food and even better medical education with emergency medicine grand rounds with MRAP. And Whitney has a fun announcement I'll ask her for. You have made the Corpendium chapter for renal and ureteral stones free to everyone here for tonight. Is that right, Whitney?
Yes. So because Dr. Weinstock is one of our ever astute faculty members, both he and Gita with UC Max and MRAP, we always appreciate the opportunity for us to join you for book clubs. And so we're trying to align your book clubs with additional references. Corpendium will make the chapter free as it's related to our case today.
Awesome. Thank you so much. And are you going to then drop that in the chat, or how should folks get to that, or just go to the website?
Oh, yes, it is mrap.org/corpendium, but I will also drop it in the chat for anybody if you want to just jump straight there.
Nice. Thank you so much for doing that. Tim Montrieff is a assistant professor at cardiothoracic critical care. So he's emergency medicine and critical care. And Tim, I just had a recommendation for you. Maybe you should get a little extra training in like pediatrics, toxicology, and orthopedics, and then you'd like totally rounded out your life, starting your career at the age of 60.
Yeah, maybe that's the next step, is just more training, more training. Being independent is too tough.
Right, exactly. Mike Pallaci and I have known each other for over a decade, and we had worked together at Adena and still working together. And we'll actually share with you a really cool thing that we did last year, which was a mock trial, not about this case, but about a similar case. So if you want to see how this plays out when something goes bad, we'll share that link with you also. And then last but absolutely not least is my co-host from UC Max, and someone I just, Gita, not to be sappy here, but just absolutely enjoy so much our interaction, collaboration, and the synergy that we have when we're working together doing the UC Max podcast, as well as some MRAP podcasts too. So Gita, thank you so much for joining. It's crazy we have not yet had you on one of these, but hey, maybe the next 9 Mondays, first Mondays, just reserved for me, right?
Absolutely. Likewise,
okay.
Mike, likewise.
All right, so let's jump right to our case. And for this critical care book of the 4 bounce back books, the main thing that we typically do with the bounce back books is look at that initial visit. For the critical care book, we really focus on that return visit, different decision points, what actually the literature shows about what you should do at the different decision points that the patient is crashing, and then what the actual provider did, and then what happened to the patient, and then we move on to our next set of decision points and literature review. For this case, we're going to concentrate just a little bit also on that initial visit, because there's some pretty interesting points and pretty interesting statistics that we're going to go with here. And there was one game-changing question that was not asked, or at least wasn't recorded. Maybe it was asked and not recorded. We'll give the clinician, obviously, because I know this clinician who is a fantastic emergency medicine physician. So I'm going to tell you briefly about this patient, as we typically do. Start with the patient story. 50-year-old woman, and she came to the ED with flank pain. And I'm going to show you her story here, and you're going to think to yourself, it's like, wow, what possibly could have been done better, because this was a really good evaluation. It says here, 51 years old, no significant past medical history, presents with right flank pain, woke up 2.5 hours ago, sudden onset right flank pain, had some mild nausea, but after attempting to drink water, she had an episode of vomiting, non-bloody, non-bilious, denies chest pain or pressure, shortness of breath, abdominal pain, diarrhea, bloody stools, dysuria, increased urinary frequency, or hematuria. She has no history of stones or pyelo. You can see her past medical history is essentially negative. And here is her evaluation. She had a back exam, no CVAT, but that's okay because we actually got a scan, which if you look 2/3 down this page here, 6 mm obstructing right ureteral stone at the mid aspect of the ureter. And when you think about this, it's exactly or pretty much like you would expect to see in the urine. She has 25 to 50 red blood cells, but she also has a little bit of leukoesterase, but it's a small amount, 0 to 5 white cells. So what happens is the patient gets prescribed Flomax, naproxen, some hydrocodone, as well as Phenergan and Miralax. And she then is sent home with a diagnosis of a left-sided ureteral calculus. So, Whit, can we start with you? In fact, I have to actually had not pulled up the other part of this, but I think you were going to detail for us the differential diagnosis and a couple subtleties on the differential for flank pain. Is that right?
Yeah, and so I think it's kind of just like the slide that you have up here. There's a lot of things that encompasses the differential for flank pain, but obviously we're all working in the emergency department. So for me, my approach is actually worst first, right? So that we don't anchor on the super benign things. We're actually trying to rule out the life-threatening things that can kill you. And so that for me would be like vascular emergencies, not just aortic dissection, but things like retroperitoneal hemorrhage, a renal artery embolism or dissection, mesenteric ischemia, that renal infarct or splenic infarct, perf, like ulcer perf, necrotizing pancreatitis. Believe it or not, any type of the spinal emergencies can present as flank pain or like a pulmonary infarct, something in that lower lobe, similar to pneumonia. So the differential is pretty broad, and obviously a history and a good physical exam helps you kind of narrow some of these things down. But I think the important thing is not to first anchor on like muscular strain or even something like nephrolithiasis, right? But to think about the most emergent things first.
So I'm going to sort of follow up on this a tiny little bit because now we do have the luxury of actually having a scan, and we have a 6 mm ureteral stone. So we've narrowed things down. And back in the very old days, when we used to do IVPs, well, we wouldn't really be able to see things like the aorta. And that was one of those big misses, is missing AAAs when a patient we thought had ureteral colic. But, that's not really present that much anymore. So let me ask you, well, actually, I'll tell you what, I want to actually, before I get back to you on that, let me sort of move to Gita, and I'm going to pull back the discharge instructions here. Pretty good, but, follow up with urology in 3 or 4 days, pretty typical. What are some things that you think maybe could have been done to really increase excellence in just the disposition and the patient understanding what potentially could go wrong in the situation?
I mean, I gotta say, it's given the presentation and it seems like a slam dunk diagnosis, and overall it seems pretty good. However, this being a bounce back makes it a little easier for me to be like, you mentioned the leukocyte esterase in your workup, but you did not really, or it seems like there was not much of a discussion with the patient. Like, it was important enough to mention in the MDM, but then there wasn't the follow-up of, if you develop a fever, if you feel worse, if that sort of chasing that down, that wasn't there. And so maybe that was one way that that things could have been expanded.
Yeah, and you always think about, like, I mean, why do we give discharge instructions in the first place, right? I mean, there are certain things, sometimes we could have some diagnostic uncertainty, we could get things sort of wrong, or there could be some sort of problem. So, Mike Pallaci, there is a game-changing question of all of these questions, and I'll just put it back to the previous slide for just half a second here, that they went through with the review of systems here. There was a game-changing question that maybe was asked but not recorded, or maybe wasn't asked, which sort of seems to me like if you would only ask one question at all, this might be the question that you would ask.
Yeah, and Mike, that's the obvious one, right? It's fever. Do you have a fever? And that's a critical branch point in your decision-making process in somebody who has a kidney stone. So, you know, failing to ask that question, failing to document it if you did ask it is really it's kind of a big mistake here. So I think we have to remember when we're documenting our review of systems, when we're performing our review of systems at the bedside, I think the best approach really is to ask the things that we're thinking about that are the most pertinent. Like in this case, it'd be the things like symptoms of UTI, which were asked and documented, fever, which wasn't documented, things that would suggest a AAA or some of the other life-threatening diagnoses. Ask those, document those, but then at the end of that, ask them just an open-ended questions. I tend to ask them something like, is there anything else that you've been experiencing? Any other information that you think might be helpful? Anything we haven't already talked about, I didn't already ask about, something like that. And then document that, they said something along the lines of all other systems reviewed and negative except as noted. I think everybody sees through that statement as kind of a templated, checkbox sort of thing that we were using for billing before the last billing and coding update. But you really have to ask some sort of open-ended question if you're going to say that.
Yeah, and Mike, you're going to share with us in just a few minutes some of the data on the likelihood of passing a stone. To me, if your pain is controlled and you don't have, like a unilateral kidney or, obviously intractable vomiting, that kind of stuff, pretty much wherever the location, whatever the size, that patient is going home. And of course, we know because of the, data on a urine that doesn't have any red blood cells, maybe 15% of the time, maybe that's because of completely obstructing stone. So, I'm going to ask a question here back to you, Whitney, and then I'm going to ask Tim, who has been very patiently waiting, if you can sort of come in and weigh in on this also. But Whitney, ultrasound actually has some pretty good sensitivity and specificity as far as making a diagnosis. But what is your go-to with this? Does it change if it's like a first-time episode of flank pain? Does it change based on the patient's age or a recurrence of the patient's symptoms? Share with us the data and then also your own personal practice with.
I mean, biggest thing is how the patient looks, right? Obviously, like a toxic looking patient, you spare no expense there. We're not going to shortchange that one. But in general, I think like just coming in with flank pain, stable vitals, we've actually, I'm one of those people that if it's a recurrent stone and they know it's their kidney stone and they're on the younger side, then I will call it a stone, put an ultrasound there, make sure they don't have hydro, and then just treat their pain because they kind of know how it goes down. But ultimately, actually, the it's ACEP's Choosing Wisely. I think it's back from 2014, but still holds true here. They have a Choosing Wisely campaign that talks about or advises against CT imaging in patients who are less than 50 years of age and have a history of stone and come in with what is uncomplicated renal colic. So their pain is well controlled. They're not toxic appearing. You actually don't need to get CTs in those individuals. And so I think for a reasonable practice, especially now that we're getting really good with ultrasound really has a good sensitivity specificity when done by radiologists. It's somewhere like 98 to 100%. And then when done by like astute emergency medicine docs, I mean, it's still somewhere 88 to 93%. So we're fairly accurate and facile. And in general, you can start first with getting the ultrasound, looking for hydro, and sometimes you can see the stone on ultrasound. And in younger patients who have a history of prior kidney stone and their pain is well controlled, you don't really have to go anywhere else beyond the ultrasound. But obviously, if they are first time stone or if they're an older patient, you do want to go with CT. It's still the gold standard, especially in the older patient population, because realistically, you're not necessarily looking for the stone. You're looking for all the dangerous emergent things that we talked about in the differential that might be masking itself as a stone. So those are my kind of delineators there.
Well, Whitney, we could not have planned that transition any better because we're going to go to Gita in just half a second to find out about those potential other etiology of stones. I put together a little table. I'll tell you about in just a second. It's pretty cool, actually. But Tim, let me just follow that up with a couple things. If you're still awake, because I know you haven't had any opportunity to say anything just yet, but what type of patient would you start with a CT and what type of patient would you start with an ultrasound? with flank pain?
When I think about flank pain and moving towards CT, I think Whitney and I have like very similar practices. I think what is their risk for anything else causing this that's going to be really bad? What is their risk for AAA? What is their risk for some sort of dissection? What is their, age as a general gestalt? Because you can't say, well, you're 49 and you're low risk and you're 51 and you're high risk. It's more of a gestalt, and then how sick they are. If they're sicker, if their age or their physiologic age is older, certainly we have a lot of folks whose age is physiologically older than their stated age, or if something doesn't feel right. I think that there's something else on the differential. That moves me more towards CT. And then on the far other end of the spectrum, if someone comes in and they say, Doc, this is my flank pain I get with kidney stones. This is my 4th kidney stone. I've been scanned 4 times. I don't want another scan. I want an ultrasound. That's really easy. If it's their classic, and that's a documentation thing as well, that I say, this is the patient's classic pain. There's nothing changed. When you think about it like a migraine, they come in and they're like, Doc, this is my migraine. This is my aura. This is what happens. I document it exactly like that and try to do an ultrasound first.
Okay, I'm going to give you 3 scenarios, Tim, and you can just say ultrasound or CT. Make it super easy. 70-year-old man, no past history of ureteral stones, has a sudden onset of severe flank pain. Are you going first with CT or ultrasound?
CT, probably I'd say CTA. Make sure there's no dissection, AAA leak, some craziness there.
Okay, and when I say CT, I know that we're saying CT for stone, but we're not also thinking, well, quick ultrasound for the aorta. So I guess that question, I sort of led you into that, but it was a little bit tricky about it. But we all sort of know what you're saying. Yeah, we need to sort of confirm that with the 70-year-old. How about the 30-year-old who has a history, and you look back on the record of 5 CTs in the last 2 years, and every one of them shows a ureteral stone?
Ooh, shared decision making and
yeah,
shared decision making and ultrasound.
Okay, gotcha. Now, how about that same 30-year-old man with no history of stones, no gross blood in the urine? Are you starting with a ultrasound and then going to CT, or are you starting with CT in that patient?
I would like to say ultrasound, but I would probably get a CT in this patient. Yeah. Depending on my pretest probability for something else, like a appendicitis or some other strange presentation of something.
Okay, so I'll tell you what I did here is the stone score. I'm not sure if everyone has heard of that. STONE is like the most bizarre like mnemonic that you've ever heard, because like the E of stone is erythrocytes. You definitely need a mnemonic for the mnemonic. But anyway, they did a score, a derivation set, a validation set, and they found that this stone score didn't work. However, what I did, and this was not like by any really high level statistical sort of analysis, but I took their derivation numbers, about 1,000 patients, the validation numbers, about 500 patients. I put them together, and again, this was not like a really well done statistical analysis, systematic review or anything, but I put together these 1,500 patients asking the question. We can get some sort of rough idea with this, and it's actually interestingly correlates with some other studies too. So, Gita, could you walk us through this? This is sort of interesting. How often, when we have a patient with flank pain, do we actually find another etiology? Because in a lot of ways, we're not doing that CT scan to rule in a ureteral stone. We're doing it to rule out other stuff.
Yeah, I think that I would reiterate what everyone has said so far, which is that the higher the age of the patient, the more likely they have additional PMH and possibly concurrent diagnoses, the better they hide diagnoses that could be life-threatening. And so I think this table bears that out a little bit. It's really interesting that it seems like in perhaps 3 to 7% of the patients, that seem like they really could have a stone, have something else, an alternative diagnosis. You've listed a bunch here in the table, things like malignancy and aortic pathology to appendicitis and pancreatitis and even bowel obstruction. I guess, the vomiting that might come along with the stone could certainly fool you in that way. And I was surprised by there's some other data in there that even when it seemed like the imaging would be like slam dunk, when that person came in with flank pain, vomiting, hematuria, and a history of prior stone, where you would think, oh, okay, like, of course you have another stone. The CT only showed a stone 59% of the time. And if it was only flank pain, then that rate dropped to 6%. So, I mean, I don't know. It doesn't sound like anything is a slam dunk here.
Flank pain recidivism. And we always would really like to have patients present like the textbook, wouldn't we? It would be so nice. Okay, so
Yes,
before we
even
get to our
then, you
bounce
don't
back
know.
visit, the folks that have waited so patiently, right? Mike Pallaci, give us the actual numbers on location and size of stone and chance of passage.
Yeah, so I think we've all been taught this as medical students and as residents, and maybe never really knew the evidence behind it. So there was a study done by Cole et al. That looked at 150 patients that presented with flank pain who had a CAT scan. Out of those 850 patients, 172 had ureteral stones, and 115 of those passed spontaneously. So they looked at what was the likelihood of passing it spontaneously based on size. So if you had a stone that was a millimeter, that passed about 87% of the time. So most of them, but surprisingly, 1 out of 8 or so didn't. If it was 2 to 4 millimeters, it passed about 3/4 of the time, 76%. Stones that were 5 to 7 passed about 60% of the time. And if it was larger than 9 millimeters, it still passed about 25% of the time. I mean, most don't, but about a quarter of them do. So bottom line is like what we've been talking about. If we can get their pain under control, even with a large stone, this is really worth a trial, a spontaneous passage at home. See if they can get it to move, if they can tolerate the pain, and give it a shot. See if we could avoid an intervention.
Yeah, and so for the last two discussion points, I'm just going to take those myself. One is about medical expulsive therapy, and really that's helpful. And it's surprising to me. There's been like basically 2 studies on like thrombolytics and stroke. I mean, okay, maybe a little bit more, but there's been like hundreds of studies on medical expulsive therapy for ureteral stones. Well, what the data shows, if you look at all of it together and systematic reviews on that also, is that if it's 5 millimeters or larger, then that medical expulsive therapy, usually with tamsulosin, 0.4 milligrams a day for 7 days, is actually helpful to increase the chance of passage. And that's actually pretty good, something like 3 to 5 number needed to treat. So it's a pretty low number needed to treat, but less than 5 millimeters is not really helpful. The good news, though, if you are prescribing it to those folks less than 5 millimeters, I personally don't, but I don't think that it's wrong or anything, is that the risk of syncope and falls and head bleeds from the tamsulosin is almost non-existent. So whereas some early studies showed that there was some potential risk with that, it's actually a pretty safe medication. So if you're doing it, I wouldn't worry about changing your practice. But if you want to just go based on the literature, it's really 5 millimeters or greater that are the stones that actually have the greater risk of passage or chance of passage with medical expulsive therapy, MET. And then the last point would be about labs. And this gets us back to our case here. So the patient had a urine, obviously 100% important to do, but are labs helpful? Well, Tintinelli actually recommends against getting a white blood cell count because, as we know, almost all the time that would be elevated because of stress demargination from the patient's discomfort. In the same way, a patient, crossing the finish line of a marathon or delivering a baby or in a car accident, right? All those patients can have significant leukocytosis, but it doesn't really mean that that's secondary to a infection. The other part is a little bit more controversial, although in my mind, it's not really that controversial because I never really got it pathophysiologically how a stone in the ureter, so I'm not talking about a renal artery embolism or something, but a stone in the ureter that has caused 1 hour of pain, that would cause a change in your renal function. Because we know that you can donate a kidney to someone, you can have a nephrectomy of one side, and your renal function could be totally normal, right? So there was a big study by Haley, 2016, where they looked at the creat, and they found that it changed like 0.1 in patients who are having stones, but the first post-stone visit from the ED went back to normal. So I personally, in uncomplicated ureteral stones, especially in younger patients, I'm not necessarily talking about diabetics or patients with hypertension, I do not get any labs on those patients. I certainly don't get a CBC, and I don't get renal function either because I wouldn't expect that it would be abnormal. Now, again, if a patient has a history of that or prolonged duration of symptoms, then I still would go ahead and do that because that would be one of the indications for admission would be acute renal failure. However, in your uncomplicated patient that had a sudden onset of pain or doing that kidney stone dance, I do not get it in those patients. So let's go back to our case. I'm going to scroll back super fast in case anyone forgot. 51-year-old woman She had this sudden onset of ureteral pain or flank pain. She has a 6 millimeter obstructing right ureteral stone. She has 25 to 50 red cells, 0 to 5 white cells, and she's asked to follow up, as Gita sort of alluded to a little bit here, with urology in 3 or 4 days. And so here's what actually happens: is the patient is discharged from the hospital, and you can see the thing here. As they're walking into the urology office, honey, you seem confused. I bet it's from the pain pills. That's her husband talking. Well, what happens is that she goes to the urologist, and it turns out that she seems confused. She's hypotensive, and he calls the squad and sends the patient straight to the emergency department. So this is where things start to get interesting, and we're going to sort of start off by our different decision points here. Decision point 1. So let me just summarize the visit back. She comes in, this is 2 days, so before that 3 to 4 day time span when she was asked to follow up. She comes in with a complaint of being confused. This had been present since the night before, slurred speech and difficulty walking. And so interesting to me, and Gita talked about the fact that most of this was really well done, but Gita talked about it, and I just wanted to sort of reinforce this concept of diagnostic uncertainty and the patient understanding really why it's important they will come back, because I promise everybody on this call that in the 150,000 to 175,000 patients in your career that you will see, you will have a patient with vomiting and diarrhea that you think is gastroenteritis, which will turn out to be appendicitis. And I promise you, there will be at some point a patient that you thought was vertigo that turns out to be a posterior circulation stroke. All these sort of things, which is why it's really important not only that we address that consideration in our note, especially when it's something serious like a posterior circulation stroke, of course, but in addition to that, we also make sure the patient understands that, so they will return if things get worse. And in this situation, this patient was confused the night before. Now, fully 12 hours later, she's going to see the urologist confused because her husband thought it was from the pain pills, not from what potentially could have happened, which was from if this game-changing question had been asked for fever. Initially, we don't know if it would have been answered in the affirmative, but if it was, it would have totally changed the trajectory of everything. And we know that this clinician was at least a little bit concerned, because they say in their discharge instructions that they're going to get a urine culture, which is sort of unusual to do in a patient who you just think has a urine showing hematuria. So what do we find here? Summarizing all that: pulse is elevated, 112. Patient is hypotensive. She's confused. Certainly, this patient is, suffering from, at least at this point, what we think would be septic shock. So let's go to our decision point here. Mike Pallaci, can we just give this patient a bunch of antibiotics and send the patient up to the ICU? It'd be pretty easy. Tim, I can ask you to weigh on this after I see you smiling, but Mike Pallaci, can we just take the easy way out, or is there a few more things that we might want to do while the patient's in the ED?
Yeah, that's kind of an obvious one, Mike. She needs source control, right? I mean, she's got an infected stone, she's got an obstruction, and she's in septic shock from it, and she really needs source control. So that's either going to be done by urology with ureteroscopy and either a stent or an extraction, or it's going to be done by interventional radiology with a percutaneous nephrostomy. But she needs drainage. She needs to have that obstruction resolved, in addition to the things that you mentioned: the antibiotics, the fluids, pressures, etc.
So let's move to our second question. Whitney, we actually have a urine culture back, and I'll flash it back here for a second. It's come back showing Enterobacter and Klebsiella. Both of those are sensitive to ceftriaxone. So question for you, and I don't, again, think there's necessarily a right or wrong answer, but is starting the patient on ceftriaxone adequate, or would you go really big with something like Zosyn vancomycin? If you do ceftriaxone, what dose are you giving, Whitney?
Yeah, so I think that, this patient comes through the door super septic and very shocky, and nobody would be knocked for just going like broad spectrum. The value, or the rare value that we have here, is what you said, was that we have a urine culture. So we can actually apply a little bit more finesse here, is we have a targeted choice. And the thing that I want to point out is that, so both of these bugs, Klebsiella and Enterobacter, those are the urea splitting organisms that we all horrifyingly remember probably from medical school, or not. And I only point it out because the Enterobacter aerogenes is the difference here in the choice of antibiotic. And so these Enterobacter infections are super gnarly and they can cause really nasty bacteremia. And so when it comes down to it, those are cephalosporins actually don't work well against this, especially first, second, and questionably, but maybe third generation. Not the greatest choice for this. There's actually a pretty decent amount of resistance even to the third generation cephalosporin here. And so if you're scaling up and you want to really cover what's going on with this patient, especially when she comes in so sick, actually Enterobacter aerogenes can only be treated or is most effectively treated using the carbapenems. So here you actually have to go with bangers. You have to go with a meropenem or an imipenem type of situation. And that's if we assume that this is not one of those Enterobacter infections that is already multi-drug resistant. Then you're looking at like tigacycline and colostin and some of those like scary ones I can't pronounce, but
Right, exactly. So yeah, so I mean, without a doubt, obviously starting antibiotics up front, and we have the advantage now of knowing this culture. And look, in this patient who is hypotensive, tachycardic, and altered, and tachypneic also, I didn't really even mention that. Yeah, it's hard to imagine that we're gonna like go too big on this patient. So I'm going to ask now Gita a question about fluids, and then Tim, if you could wrap all of this up together for us with a little bow before we see what the actual provider did and then what happened to the patient. So, Gita, we've ordered a 2-liter bolus, and say we get 2 large bore IVs and we sort of slam that in over 15 minutes. I mean, just for example, how long are you waiting to see if the pressure improves, and how much improvement are you going to be satisfied with? And if there's not improvement, what is your next step going to be?
I'm not waiting long. I think
Okay.
this person's quite sick, and you know where this is going. If you've seen this movie before, then you probably know that, like, of course, if she really doesn't have a ready response, not only in blood pressure, but in her mental status. Is she really perfusing well? I would have a pretty low threshold to going ahead and starting the pressors in this patient. I mean, they may need more fluids thereafter, but I think that initial bolus somewhere around the 30 per kilo range is where we'd all want to start. But I would be pretty, I'd have a very low threshold to starting pressors.
Okay, Gita, and I'm guessing like Levophed would be probably where
Yep.
you go with the pressors. Okay,
Yeah.
awesome. So, Tim, before we ask the last question about repeating ultrasounds to Whitney, Tim, we've actually had some pretty strong statements, and I'm going to just guess that a lot of us would agree with these. What other subtleties would you throw in there, just as far as source control, antibiotics, and fluids, based on what everyone said here, and maybe some extra experience you have from the ICU?
So I would, putting on my ICU hat for a minute, helpful things upstairs. Certainly, if you give marrow and vanc to this patient, nobody's going to bat an eye. That's fine. But the next level, if you have it at your hospital, is to get like a MRSA PCR. So it's a nasal swab, right? And there's a lot of data looking at if you have a negative MRSA screen, that is a very high negative predictive value for having MRSA in your blood, in your urine. And so as soon as you get that in the ICU, we're cutting out the vanc. So if we have a known source and we don't think there's any MRSA coverage necessarily needed, get the MRSA PCR, and then I can stop it upstairs and hopefully avoid a lot of issues. And with that, the timing of antibiotics actually matters. So we talk a lot about getting antibiotics in fast, getting them in really early, but the antibiotic that should go in first should cover the gram-negative organisms. So there's even some data looking at giving vanc before meropenem or meropenem before vanc, and there's an association with decreased mortality if you give that gram-negative coverage. So give the meropenem up front, add the vanc on later, add your MRSA PCR, and your intensivist will be happy. And, yeah, you know where she's going. She's going to go to the ICU. So give her fluids, work on source control, get the antibiotics in. You don't have to like restart all of her home meds and do a great med rec and give her DVT prophylaxis. But, like some of those things, get those done and send her up.
Okay, so I just want to let everyone know, if folks want to put questions or comments in the chat, these are super scary patients, and this is really one of the big ways. Obviously, a patient with ureteral stones can go south very quickly. So, Mike Pallaci, just yes or no question here. Are you doing those VANC swabs in your emergency department?
I am personally not. You probably saw my facial expression when you said it. That's some new information for me, so I'm learning something tonight. But there may be docs that are. It's not something we've talked about as a group. I'm not sure whether it's available in my department. It may be. I'm pretty certain it's available in the ICU, but it's not something that I've personally seen done in the ED. I'm curious to hear from the rest of the group because I love this idea.
Yeah, other folks have you guys doing this at all? Because I've heard of this also, and that it has a really good sensitivity to be able to stop the vancomycin. But I have not heard of or seen anyone in my ED do that. Anyone else getting that in their EDs?
Not in the ED that I've seen, but certainly in the ICU, they're doing that right away.
It's also interesting to me that thought that like it's exactly the right thing. I mean, obviously you would never lose a legal lawsuit for like ordering, two big gun antibiotics. But interestingly, some of those, and we're doing a lot of push antibiotics now, which is really nice. But some of those antibiotics that take a while to drip in, well, if you start one that has less likelihood of covering what you think you probably have, well, you might be actually delaying the care that's going to help that patient by an hour. So maybe even that conversation with the nurse or the pharmacist, as far as which one should go first, could be sort of, again, that next level of excellence in care.
Well, yeah, certainly the
So,
VANC, if
yeah.
you're trying to, I mean, VANC is one of those things you can't really slam in without really worrying about red man syndrome or whatever kind of other side effects. So you want to time things well, depending on your access, of course.
Yeah. So, Whitney, here's a Fisher cut based type of question to you. You're at the bedside of the ED, which is what we try to do with all of these cases with the Bouncebacks Critical Care book. So you're at the bedside, and you've done your stuff. You got the antibiotics, whichever ones those are. You got the fluids. Two questions for you: Are you repeating the CT scan, or are you repeating any imaging? I guess that's one question with two parts. But then the second question is, are you calling the urologist or interventional radiologist up front, or are you waiting until you have confirmation with the repeat radiologic study that the patient still has a stone? And then I'll ask everyone else what their thoughts to weigh in on this here.
Yeah, sure. So I think the value of letting this patient, I'm assuming, and we don't know at this point yet, based on what you presented so far, what her response has been, or if she's still essentially hypotensive, because there's no worse place to run a code than in the CT scanner. I hate doing that. So I would say the patient shouldn't leave the department unless you are moving them in the right direction with your resuscitative efforts. Let's, not forget that. And then the other question is the value of the other CT image. I know that this patient is back with septic shock, altered. She's encephalopathic from a known obstructing stone. So in my head, as I'm doing resuscitative efforts, IR is the first person that can help me with that. So I'm getting them on the phone fairly early, especially in places where you're having to move fast and see a lot of patients, and you really want to get these resusces done well up front. The only value I could think of sending the patient back for another CT scan, and it kind of alludes to what Dr. Pallaci was talking about with source control, is if I think that this goes beyond septic shock from just an obstructing kidney stone. So if this patient has now developed an abscess, and we're talking about things like source control, the abscess is what we're going to want to know about, or even worse, if they've now started developing infarctions or they have some other confounder here that's not just purely the sepsis from the obstructing infected stone, that would be the only utility in sending her back for another CT. And again, that would be after we have stabilized this patient and she's good to move forward. But ultimately, it's continue my resuscitative efforts, get IR on the phone, because usually urology is going to say something like, too unstable for me to do anything. So IR is my first call.
Yeah. Well, I think
One thing I
that
have to
what
say
we've
about that,
localized
is this
here.
patient not coming from the urologist office?
Right? So exactly. I'm not calling
The
urology
urologist should have
first.
been like, I'll be right there.
And this is a compliment to us, right? the urologist is sending a urology patient to us in the ED, right? Because we give great urologic care. So let's do the glass half full, right? So, I mean, this is actually, we've localized out several different ways to really have excellence in care. One, we've thought about the history, making sure, of course, we asked about a fever. We have thought about a patient who's getting antibiotics, making sure the one that's most likely to be effective is given first. We've thought about calling either urologist or interventional radiologist, if that's available, right up front, because that's going to be the big thing that's source control, like Pallaci said, as far as making sure that we don't delay anything further. And then, all those other things that we would typically do, the fluids and the antibiotics and all those kind of things are real important. So let's move forward. And for anyone that hasn't really looked at the chat, there's some really, really great references on this in the chat. So what did the actual provider do? So you see the patient came in at 327. We're seeing obviously right away with this type of patient, 342. Soon after that, here's what they documented. Upon recognizing clinical sepsis, they ordered CBC, a bunch of labs, fluids, ceftriaxone, and now the labs start rolling in. So now the patient does actually have acute renal failure, probably not because of the ureteral stone, although I'm sure it's not really helping things, but probably because of the sepsis and the hypoperfusion, right? As well as a lactate of 5.8. So clearly the patient does have septic shock. So we're going to our next step here. And the patient, I will tell you, is very agitated and combative. And you think to yourself, like, how combative could this person be with a blood pressure systolic of 81? And I will tell you this, that there were multiple security guards in the room, as mentioned on the chart, from the actual record itself, that they were like holding the patient down. So let's sort of move to this next point here. Gita, you got a combative patient who's hypotensive, septic shock. She's altered, obviously. What are you doing for sedation on this patient with an eye towards not making that hypotension worse?
I think we've all been in this situation before. It's a really tough situation to walk. I mean, this person is heading towards intubation. You need to take control over this situation. Like, this is the security guards and you can't let things stand as they are. And so clearly you're going to have to start with sedation somewhere while you're planning your intubation and going from there. You're going to want to pick agents that have a lower chance of decreasing the blood pressure. This is also an older patient, so you're going to probably start off with pretty low doses. I mean, as fast as you want to get there, you want to get the situation under control, but you also don't want to slam this person, oversedate them before you're ready to take care of an airway, or really just make them more hypotensive. And so, starting with a low dose of something like ketamine, something like low dose etomidate, maybe a tiny dose of Haldol, something like that. I would start low and then be prepared to redose after that. You might want to be ready with something like, we've got her on pressors still, or have we? Sorry, I got lost. We did start her on pressors already.
We have not yet started pressors.
Oh, we haven't. Okay, yeah. So, I mean, these are all things that you're going to be doing. You're probably going to need pressors. Maybe while you're getting ready, you could think about push dose pressors while you're on your way. But you're going to have to give her something, and I might start with something like ketamine or low dose etomidate.
Okay. And I will tell you what actually happened. We'll jump to this fast forward in just half a second. Was given a milligram of Ativan, or maybe it was 2 milligrams, without adequate sedation, still security guards holding that patient down. So let me jump to you here, Whitney. I'm putting you at the bedside. The patient is obviously, for all matters, getting worse. She has not responded to fluids. She remains hypotensive. She's super combative. There's no way that we're able to actually even get this patient over to interventional radiology or to get a ureteral stent based on her degree of agitation. On the other hand, we do know, based on the study by Hefner, that a patient who is intubated before adequate resuscitation, in other words, a hypotensive patient, has a high chance of arresting. And if they do arrest, there's an 82% mortality with that period intubation arrest. So it's a very fine line that we're walking here. I'm going to put you back to the bedside, Whitney, and then we'll take a vote with everybody. You can just give sort of a short answer to this one, just because we want to make, in the interest of time. Whitney, are you going to intubate this patient at this time or do some more things first?
Oh, I am intubating. I'm gonna have my
Okay.
pressors, like Gita said, either push dose or have some hanging. But this is a matter of both patient safety, staff safety, and continuing resuscitative efforts. So.
Awesome. Let me go around the room. Mike Pallaci, intubating or doing some other things first? And if you are, very briefly, what are you doing?
I think it's tough to say without having a visual at the bedside of what the situation's like. From what you're describing, I mean, honestly, the best way to get control of this patient, I think, is to give her ketamine, is to give her
Okay.
IV. If we have an IV in place, and we can give her IV ketamine. If not, to give her IM ketamine, and then you got some time, and then you
And
could
what dose would you
intubate her
give of
once
the IV? She does have that IV in with the fluid she got.
if she's got an IV, I'd give her 2 mg per kg, and I'd just do that IV push.
Okay. All right. Gita?
Similarly, I think I'd want to see where I got with the sedation if I were going with ketamine. Where am I now? Can I get the blood? Ideally, you'd like to do a little resus before you intubate her, but if you can't get that room
Right.
under control, you're just going to have to do it. Your push is going to come to shove.
Right. And we have
And
done some
that's the point
resus
that
with the 2 liters of fluid too, right?
yeah, yeah, and that's the point I was going to make. If we do get to the point that we need to intubate, I mean, this patient is at high risk for peri-intubation hypotension and arrest, right? So if you could avoid the intubation or do it once you've got more resuscitation done, that's obviously optimal, and the ketamine at the same time can support her blood pressure.
Okay. Tim, what is your how do you weigh in on this?
So this is probably more of a logistical issue in wherever you work. But if I were like in the emergency department I work in, primarily I would give ketamine, small doses, so like 20 milligrams at a time, and within 15 IV. So within 15 seconds, you'll see if someone's out of it. Some rotary nystagmus, they're a little bit less responsive. And then I would probably take a little bit more time to set up resuscitate, get some more blood, maybe if you can get an arterial line, get like some stuff set up, because this is not primarily an airway problem. This isn't a gas exchange problem. This isn't oxygenation. This isn't a ventilation problem. This is a mental status, and get everything set up for IR to have a really beautiful nephrostomy tube placement. So you probably have a little bit more time than somebody who comes in who has this massive aspiration, they're satting 30%, everything's, going poorly. So I would probably give a little bit of ketamine, resuscitate her, start some pressors, give some more fluid, try to tee her up for a really smooth intubation if possible.
Okay. All right. And we do have those patients where they remain, despite all of our best efforts, remain hypotensive, right? And I had one just the other day like that. And then at some point you're going to say, as I did, well, it's just time to intubate that patient. And certainly we wouldn't want to delay source control for lack of having that patient adequately sedated. If again, IR or urology was doing that. So interesting, a lot of different experts and a lot of different thoughts on how that would do and how we progress with that, as well as with doses. So Mike Pallaci, real briefly, like 30 seconds or less, one thing that might make us reluctant to do pressors because we'd have to do a central line, but now we know that we can safely give pressors with a peripheral line.
Right, and this information has been out there for a long time. I think it's become more and more accepted. The short answer to the question is, like you said, yes, we can safely give pressors through a peripheral line. There was another study in addition to this one, another in a long line of evidence in this that came out in Chest just a month or two ago by an author named Yerke that showed the same thing. It's safe, it's effective. As long as you have a good IV, 20 or 22 gauge, do it.
One thing that's absolutely fascinating to me in this Cardenas Garcia group with about 734 patients, well, exactly 734 patients, is that, and that's what I highlighted in purple there. Interestingly, after these peripheral dose pressors, after maybe fluid resuscitation or antibiotics kicked in or for whatever reason, only 13% eventually required a central line, which is sort of astounding to me and a really, really good argument, not only because there's not harm with peripheral dose vasopressors, but because most people will not eventually need continued vasopressors through a central line. Only 13%, which is absolutely fascinating. So I'm going to tell you what the provider did. We're going to skip the last question that we were going to talk about. The urine returned, the blood pressure is now in the 70s, despite 5 liters of IV fluids. This is a IV fluid believer for sure. And I have to say, through most of my career, I've been very much of an IV fluid believer too, not only just with my patients, but also personally. Water is pretty good, right? So the patient, interestingly, they tried to get a central line, and that's why they gave initially that Ativan, and then they gave the fentanyl. And you can just envision it. We've all probably been there at some point during our careers, maybe when we were residents, right? Of like standing at the bedside with like a gown and mask and hat that is soaked in sweat because you just can't get that central line, right? And fortunately, the times that that's happened with me and probably Mike and Gita are the only ones that can probably remember is before ultrasound. But fortunately, with ultrasound, that's not as common a situation. But anyways, this provider, this clinician, this physician actually was not able to get a central line. But I think about myself, the amount of time that was sort of wasted with that. That's 1708. Here we're at 1350, right? So we're talking, at least an hour, but maybe an hour and a half later with this attempt of getting set up for the central line and doing all this kind of stuff and that source control, Mike, that you had talked about. But eventually they did get the patient with the norepinephrine. And so let me briefly do this because we want to make sure that we end right on time, again, with the time that folks have given us. And Whitney, for rapid sequence intubation in this patient, because you said you would intubate the patient, and look, that's exactly what eventually happened with the patient. And I will tell you, that's what the physician did too. And they turned out fine. But what medicines would you choose for RSI in this patient, Whitney?
Yeah, I think it's kind of like everyone said, including Tim, who mentioned that this isn't a dynamic airway. It's not a crash intubation. So most of us are realistically doing DSI, delayed sequence intubation. And in this case, the ketamine that we were attempting to use to sedate her is also a good choice for intubating her as well. I think any of the sedating medications that you use, I know we talk a lot about them causing hypotension and which ones are less likely to cause hypotension, but realistically, it's taking away sympathetic tone that always makes you likely to have transient hypotension after intubation. So even if you use ketamine, just taking away that adrenergic drive on that patient, you might see some transient hypotension and you might still require the pressors or a push dose epi or phenyl stick in that case. So just be prepared for those.
Awesome. And so, Tim, I'm going to just skip straight to you for these last couple of questions and maybe like a total 45-second answer to them. And then we'll get some sort of summary points for all of this stuff. But vent settings as well as meds for sedation in this patient who's still hypotensive in the 70s after 5 liters of IV fluids.
So vent settings, for lack of a better term, you can pretty much do whatever you want. So volume assist control, pressure assist control. You aim for a target tidal volume of somewhere around 6 milliliters per kilogram of ideal body weight. So get out your tape measure, go to MD Calc and calculate that out. PEEP 5, FiO2 40, 50, 60%. Again, for patients who don't necessarily have an intrinsic lung problem, the big thing you're going to be doing is making sure that that tidal volume is good, because in the ICU, we tend to be a little lazier and we just follow whatever the ED does. So the settings stay the same throughout the course, and we have literature showing that. As far as sedation, so the idea in the ICU is primarily you should use analgesia, and then if the patient is still dysynchronous with the ventilator or otherwise restless, add on some sedation. So for me personally, the first thing I go with is some sort of opioid, so fentanyl, pushes, or a drip if the department's busy and things are pretty crazy. Start a low dose fentanyl drip and then titrate that up to effect, and you'll find that you end up needing a lot less propofol or Precedex or any other sedation.
Yeah, and certainly if you're doing a procedural sedation, like giving that opioid before the propofol, that always makes, at least in my experience, that work better also. So let's find out what actually happened with the patient. They attempted the femoral central line, was too combative for successful placement, did not get the ketamine that folks recommended. So they intubated the patient, and the patient then was intubated actually with etomidate and sucks. And it sounds like that was done pretty easily. The patient did not crash and have a peri-intubation arrest. They went to interventional radiology and had placement of a nephrostomy tube. They had a copious amount of drainage of purulent material. Unfortunately, this patient actually did leave the hospital, and that's not our case there. They did leave the hospital and did well. So what I'm going to do is flash up the CME credit claim here while I ask each of you to give me about a 30-second summary. Now, before you do the summary, and while we have folks on here, just a couple quick points. First is that our last Bouncebacks Book Club, chapter 22 of this sort of academic year, is the first Monday in May, which is May 6th. You can register for that at EM Bouncebacks. I'll put that QR code back in just half a second, embouncebacks.com, and then we'll start back up again in October. And through the next academic year, we will finish the Bouncebacks book, which is very exciting. And also, another point is if you want to see a trial as to what happens when a patient with an infected stone dies, you can see the trial that we did at Mike Pallaci's emergency medicine residency at SUMA about a year and a half ago in the fall, or was it just this past fall? And that's also on that same website, the embouncebacks.com. There's a link right on top, and you can watch the whole trial. It's about an hour and a half with actually a plaintiff attorney, defense attorney. Mike, you were the expert witness on one of the sides.
Not in that one. That was a different one. I was the expert witness. I was kind of in the background, but some of my partners as emergency docs
Okay.
and my residents was a defendant. So yeah.
Okay. Yeah, but it's pretty fascinating anyway. So let me flash up the QR code again here, and why don't we just sort of go in alphabetical order? I'm not sure if I could do that in my head, but I think Whitney, you are the first in the alphabetical order. A couple points that you want people to remember after this hour tonight.
Yeah, so I think just shameless plug for bedside ultrasound, because I'm a big proponent of that, especially in resuscitation. Before you slam 5 liters into an individual and then send them to Tim in the ICU, where he has to then diurese what is inevitably ARDS that happens after that fluid overload. I would just, let your bedside ultrasound guide your resuscitation. If you've gone the 30 cc's per kg and you put the ultrasound down and the IVC is plump, clearly more fluids is not the answer for the hypotension. You need to start looking towards early pressors in that case. So yeah, don't forget about your ultrasound.
Awesome. All right, Tim, alphabetical order. What would you like people to take away from tonight?
For pretty much any sick patient that you're giving some sort of beta-lactam, cefepime, zosyn, meropenem, and vancomycin, get that beta-lactam in first. It's probably going to help the patient. And then if you're going to go to the next level, get that MRSA PCR, make me happy in the ICU so I can take off the vanc when it's negative.
Perfect. And you put up a really nice reference in the chat to that, so folks check that out. Mike Pallaci, you are up next.
I think that the second half of this conversation really pointed out something that I try to stress all the time with my residents, and that's that we really need to have complete mastery of the medications we're using for procedural sedation and for RSI, what the pros and cons are, what situations we should avoid them, what situations we should use them with caution, and which situations where they are the drug of choice. And you're not going to do that unless you really understand all of the pharmacology of those, 3, 4, 5 different agents that we're thinking about using.
Right. I mean, there's really not tons of them. And with experience as well as book learning, then we can be masters of those. So Gita, wrap us all up, put a bow in this night.
The only thing I would really emphasize is that this diagnosis, I think some of the fastest sickest patients that I've seen go downhill have been patients with infected stones like this. And I would say have a very healthy respect for this. It has at least a 30% mortality when it's not addressed really, really quickly. Keep it in mind when you've got the patient, sort of the opposite scenario too, where you have a patient who has you think it's a pyelo, and they're not getting better and they're getting septic. You should think to yourself, could this person have a stone? Because those two things, an infection and a stone together, is just a really bad combination. It's something that you should always have top of mind when you're in this type of scenario and the patient's looking sick.
Love it. Well, thank you all so much for taking your time tonight to share your fantastic expertise. I learned a lot, and thanks to folks who have come on as participants tonight. Hopefully this was true to the time that you shared with us. We will look forward to seeing folks on Monday, May 6th. And all of these episodes are recorded and on that EM Bouncebacks website, except for the very first one. So there are now 20 of them, which are chapters 2 through 21 on there. So pretty exciting to be able to say that. Thanks again to everybody, and we'll look forward to seeing you next time.
Have a great night, everyone.